And so today we're going to be talking about oral chemotherapies in the hematology and stem cell transplant setting. And I, of course, appreciate the generous introduction. So whenever we look at oral chemotherapies, I always think of things starting with class, and that's how we're really going to be able to quickly come up with ideas of what the toxicity profile as well as indications are for those things. And so we're going to start with class and indications and then look to relevant adverse effects. And then from there, as on a pharmacist side, we're going to be looking at drug interactions, dosing, and administration for these medications that'll be important for you guys. So here's the overview of where we're going today, and certainly a lot of ground to cover. So we'll start with our original blockbusters with the BCR-ABL inhibitors in CML, move on to the IMiDs and myeloma, and then switch over to our B-cell disorders with the BTK inhibitors, PI3 kinase inhibitors. Venetoclax will kind of be our bridge between those and AML, where we get into our targeted AML therapies with FLT3 inhibition and IDH inhibition. And then we'll round it out with our retinoic acid derivative and APML, as well as our JAK inhibitors. And so starting out then with our BCR-ABL inhibitors, our first gen is imatinib, second gen is dasatinib, nilotinib, and bosutinib, and third gen is ponatinib. So starting out, this Gleevec is our first blockbuster oral chemo agent, 2001, cover of Time magazine. This is going to be a cancer revolution. And so things have kind of switched more towards immunotherapy and things like that these days, but I think these are still certainly important steps forward in cancer treatment and something that we need to treat uniquely as they are. So BCR-ABL is a fusion protein resulting from a 922 chromosomal translocation, leading to what's known as the Philadelphia chromosome. This causes constitutively active tyrosine kinase, which leads to uncontrolled cell growth. This is most commonly associated with CML, where it's essentially a malignancy-defining feature. However, it is a consistently documented subgroup within ALL, and then it can be seen in other malignancies, and then especially imatinib can also, due to its non-BCR-ABL related effects, also be used in other cancers, so you will see these in some other places. So looking at our dosing considerations, you can see from a daily dosing standpoint, nilotinib is going to be our one standout that requires twice daily dosing. Most of these are not going to require any renal adjustment with the exception of imatinib, but they are all going to be hepatically metabolized. And so whenever we look at the metabolism, the standard for our oral chemotherapy agents are that they're going to be CYP3A4 substrates. So important here is I've had a few epilepsy patients who we've been trying to start on therapies, and that's always a challenge due to the strong induction of some of those agents. The things like azole antifungals or solid organ transplant recipients, especially on the imatinib side, where it can both influence those immunosuppressants as well as be influenced by things like azole antifungals. Looking at food interactions, the standout here is nilotinib, which requires empty stomach, and in combination with that being a twice daily metabolism, I guess this is the biggest drug that might be a red flag for patients who have adherence challenges, since giving a drug twice daily on an empty stomach can certainly be a challenge for a patient. Imatinib, dasatinib, and bosutinib are recommended to be given with food, and that's more for tolerability purposes. And then from an acid interaction standpoint, the entire second-gen agents will all require an acidic stomach for absorption. And so the recommendation is to avoid H2RAs and PPIs completely in these agents. The personal preference of mine is that the FDA does have recommendations sometimes on spacing H2RAs where it can be permissible. For this, I think less is more, so the more we can avoid that acid interaction, the better. And then if patients do have, a GI history or something like that they require it, then we can really broach that on a patient-by-patient basis. But generally, they should be altogether avoided for these second-gen agents. Looking at our class toxicities, that's going to be bone marrow suppression, neutropenia, anemia, thrombocytopenia, as well as rash. And then each agent is going to have its own unique toxicity profile in addition to that. So for imatinib, we do have fluid retention as a potential side effect. The big one I think of is periorbital edema, so looking for things like vision changes in patients. This does seem to be the most GI toxic of the inhibitors, so hence that administration with food and the potential for nausea. And then it can have other like musculoskeletal effects as well. Dasatinib is also fluid retention, but here we've seen more pleural and pericardial effusions. And then this one seems to be the most thrombocytopenic driving and also has additional platelet inhibition. For Nylotinib, I kind of think of this as the cardiotoxic one, so QTC interval prolongation. So we're going to need that at baseline as well as after a patient starts therapy. We also have the potential for peripheral arterial occlusive disease as well as metabolic syndrome, and then pancreatitis in these patients as well. Bosutinib, we also have fluid retention as a potential side effect in addition to hepatic toxicity and diarrhea, probably why we have that one also being recommended to be administered with food. And then ponatinib is kind of our last line therapy for only those patients with the 359 mutation. And the reason for that being, it's always terrifying whenever you have to counsel a patient on this medication and tell them about, increased risks of heart attack and stroke, vascular occlusion. These are all scary things for patients, and rightfully so, I would argue. So that's why it's reserved for only patients who have failed other TKIs or have a mutation that's resistant to the rest of them. The other things noted here are hepatic toxicity and pancreatitis and hypertension. The one, cool thing with the BCR-ABL TKIs is it's one of the few oral chemo agents that has really good data for how important adherence is to the success of therapy. We always assume, and I think know intuitively, that it's a key part of any oral chemo regimen, but here we actually have the studies to back it up. And so adherence has been identified as the most important factor for cytogenetic relapse and imatinib failure. And the one study that looked at the adherence outcomes found that non-adherence is associated with a poor response. Those with a suboptimal response were significantly more likely to be non-adherent. And then patients with an adherence rate less than 85% had a 1 in 4 chance of losing their cytogenetic remission at 2 years. So quite likely, if you're missing that 85% adherence is, about 4 doses a month, or missing maybe 1 dose per week for our once daily TKIs. In terms of trying to think who is at risk for non-adherence, we would be thinking of patients who are younger age, those experiencing adverse effects, those requiring a dose escalation, or people with high copays. And so this is something that should be emphasized essentially whenever we're starting therapy, and then any kind of break point where we might be seeing a patient who is having a suboptimal response or experiencing side effects, we should be continually screening for adherence. So that brings us to our assessment question. QR is a 27-year-old male, started on Nylotinib as first-line therapy for CML. He is noted to have a suboptimal response to therapy on BCR-ABL testing, which of the following may contribute to a suboptimal response. I'll read through the responses, and then if you could just put answers in the chat, it would be appreciated. And so is it A, concomitant carbamazepine use, B, using lansoprazole as needed for heartburn, C, occasionally missing evening doses, or D, taking with food, or is it E, all of the above? So I'm saying that the majority has it correctly with E, all of the above. The reason being carbamazepine is one of our anti-epileptics enzyme induction molecules. So any patient on one of those, we need to probably be working with their neurologist to see if there's an alternative we can use. Lansoprazole are PPI, so Nylotinib second gen, all of those will require an acidic stomach for absorption. Adherence is always going to be an emphasis in these patients, and then Nylotinib is our one agent that's required to be taken on an empty stomach for absorption purposes. So great. That brings us to our next, probably most commonly used group of agents, which are the IMiDs, and so that's thalidomide, lenalidomide, and pomalidomide in myeloma. And I'll take a slight historical detour here because I think it's instructive in terms of why these agents have all the requirements around them that they do. And so thalidomide entered the German market in 1957 as a non-barbiturate sleep aid and was also used for relief of morning sickness. It was first associated with birth defects in 1961. And then you have one of the great kind of heroes of U.S. Drug history, which is Francis Kelsey, who is credited with preventing the medication's approval in the U.S. despite strong pressure from the manufacturer and supervisors. She was essentially like blasted in the media for preventing this. And of course, later on, we found that thalidomide could lead to fecomelia, which is a condition of short naps in their flipper-like limbs, documented there. And then this led to the Kefauver-Harris Drug Amendment Act in 1962, which is a little crazy thinking it was only 60 years ago that drugs needed to be demonstrated to be safe and effective prior to marketing. So I guess we should at least be appreciative that that's now the standard. And then in 1998, thalidomide was reintroduced to the market. And so because of this historical teratogenicity that was widely introduced to a large population of people, all three IMiDs have similar REMS programs, with the goal being to prevent risk of embryo-fetal exposure and to inform prescribers, patients, and pharmacists on the serious risks and safe use conditions. And so in some ways, this is a closed system so that only you have to be a certified prescriber in order to write for a prescription, and then a certified pharmacy and able to fill the prescription. And so requirements then on a prescriber side are obtaining an authorization number for each script, listing that and the patient risk category. So example, non-reproductive female on every script, and verifying a negative pregnancy test for all females of reproductive potential. I would say the nurses are very helpful in terms of making sure that's documented, but if you're practicing at a community center, that might not always be the case. And then from a prescribing standpoint, this is really more restrictive even than our C2s, so that you can only get a max prescription for 28-day supply and you require a new prescription for each dispense. From a patient side, this is also a little burdensome, requiring them to complete a confidential survey prior to filling each medication or filling the medication every time. Reproductive females must use 2 effective methods of birth control for the duration they're on the medication. And then pharmacies have to obtain an additional number, as well as completing an education checklist for each patient prior to every single dispense. And so that brings us then into the IMiD mechanism of action. And this is a little bit of hand waving. It's multimodal, not completely understood. So there's a couple different hypotheses here. And I think we see this different effects in various places with the drug. And so there is some sort of direct cytotoxicity and apoptosis on the cells. There is a thought that inhibition of IL-6 release might decrease myeloma cell adhesion. There's also an angiogenesis mechanism to it, and so that might be part of the reason for some of our thrombotic effects associated with it, that we also see with other angiogenesis inhibitors. And then there's also an immune upregulation component to this with enhanced cytokine production and natural killer cell-mediated cytotoxicity. So looking at our agent overview then, all 3 of them are going to be indicated in multiple myeloma, with lenalidomide being the standout and having indications in different lymphomas as well as myelodysplastic syndrome. From a dosing schedule, these vary a lot between different regimens, but thalidomide is generally given daily versus lenalidomide and pomalidomide. The most common schedule is 3 weeks on and 1 week off, but once again, there's a lot of variability in that. They're all pretty different from a metabolism standpoint. Thalidomide is hydrolyzed in the periphery, which is nice and easy. Lenalidomide is predominantly renal excretion, 82% via unchanged drug, which is going to be really important in our myeloma population that has a high incidence of renal dysfunction. And then pomalidomide is going to be hepatic metabolism, so more what we think is typical with oral chemo agents. Looking at our adverse effects profile, the embryo-fetal toxicity is going to be class-wide. And then we have that thrombotic risk, so DVT, myocardial infarction, and stroke. And because of that, so likely related to those angiogenesis effects of the medications. And because of that, thromboprophylaxis is going to be recommended in all these patients. Variety of things used across the country. Our most common regimen is aspirin, 325 milligrams, unless patients have, prior bleed risk or a prior thrombosis, where we'd be using something like apixaban. We also do see rash in these patients, and it feels a little bit of like an immune activation rash, maybe similar to checkpoint inhibitors. This isn't a penicillin rash that develops 24 hours, but it's usually a day or two after, 1 to 2 weeks after a patient's been on the therapy. And then that rash does tend to respond well to holding therapy, re-challenge, and potentially dose reduction, depending on the severity of the rash. Infection, also due to the cytotoxicity of these agents, is going to be a class-wide effect. Looking then at our agent-specific side effects, and I really like the graph at the bottom. I think it's helpful for comparing these agents. So thalidomide is going to have a lot of neuropathy as well as fatigue. This is why it was used as a sleep aid initially. Lenalidomide and pomalidomide both have dose-limiting myelosuppression, so that's going to be one of the major monitoring points for that. Lenalidomide also has the potential for renal toxicity, which once again is going to be a big concern in our myeloma population who frequently has AKI at diagnosis. And so that's why in some of our patients, we might initially omit the lenalidomide until we get the myeloma under control or some semblance of control. And then the secondary malignancy potential for lenalidomide is something that likely you need to be counseling patients on at time of consent. Not common, but consistently documented, so something patients probably need to be aware of. Leading us then towards our B-cell malignancies with Bruton tyrosine kinase, or BTK inhibitors, with our first-gen agent being ibrutinib, and our second-gen agents being acalabrutinib and zanubrutinib. And so BTK is integral to B-cell receptor signaling, which is constitutively expressed in a wide variety of B-cell malignancies. And so by inhibiting that expression, then we can lead to cell death and inhibition of cell migration and proliferation. Different binding among these agents then, ibrutinib first gen, not surprisingly, has the most off-target effects, which is why we attribute it to having a broader side effect profile. Different selectivity for BTK binding, and then at the moment, these are all covalent, irreversible binding, but it is expected there's some drugs in the pipeline that would be non-covalent binding and potentially have some benefits of non-covalent binding. So that's something that we're looking forward to in the future. So looking at our FDA approvals, ibrutinib, kind of similar to imatinib, oldest drug on the market, so has the widest variety of them. The most common places we'll see it are the CLL, mantle cell, and marginal zone, and then the chronic graft versus host disease approval is something that it was the first drug to have an approval in chronic graft versus host disease, although with ruxolitinib and belumosudil coming on the market, so it's kind of fallen to the back of the line at the moment. Acalabrutinib is also licensed in CLL, and then zanubrutinib and Waldenstrom's, and all three are licensed in mantle cell. So looking at our dosing schedules then, ibrutinib is given once daily, acalabrutinib is our standout at twice daily, and zanubrutinib can't decide what it wants to be, and the FDA approval for that actually includes both dosing regimens. I've talked a little bit about this with Dr. Chang. We haven't been able to find any reason why you'd really want to give it twice a day, so I'd assume we'd be starting people on once daily. So I'm just a little bit surprised that that's actually in the approval. It isn't like indication specific. It literally just lists both of them for it, which is a little strange. None of these have renal metabolism, which is, standard for our oral chemos. They do require hepatic adjustments and do have 3A4 mediated metabolism, which is going to be especially important for a class of drugs like this that is common or does commonly cause atrial fibrillation, where you can see non-dihydropyridine calcium channel blockers like diltiazem and verapamil that are moderate inhibitors and do require adjustments in these medications. So that's one thing for you to watch out for. And then acalabrutinib is our medication that has acid interactions. So once again, patients who are on anticoagulation or might have a history of GI bleed, that's something that we need to be aware of and can be a challenging decision between ibrutinib and acalabrutinib in those patients. So looking at our toxicity profile, and this is based on package insert recommendation or package insert percentages. And so ibrutinib being the most dirty of the kinases in this class, we expect atrial fibrillation and bleeding are the most common with this compared to the other two. Zanubrutinib, you can see, had two trials. The one looked spectacular. The one was a little bit higher, so I suspect the truth is somewhere in between. Also, we see the most diarrhea and, in my experience, rash with ibrutinib as well, slightly less common in the other two. And I guess I would say the diarrhea with ibrutinib can be, grade 3 severe where it requires dose reduction, so something to watch out for. And then the headache is really a standout with acalabrutinib, occurring in 40% of patients per the package insert. Although that is mostly grade 1 and 2 and does tend to respond to Tylenol and caffeine, so not something I typically think of as being a dose-limiting side effect. And then looking at, so this is a trial that was published recently in JCO, and I'd say it does turn that traditional thinking with acalabrutinib as being better tolerated, or it has me questioning it. So this is a head-to-head comparison of acalabrutinib versus ibrutinib. It did meet its endpoint of non-inferiority, but I must say I was a little unimpressed with the major bleeding and atrial fibrillation, just based on what we had seen in package inserts and the single-agent trials. I thought that it would be more reduced with acalabrutinib, but I'm a little less than impressed with what we actually see in the atrial fibrillation and bleeding here, which I think it's tough to say that this is really clinically significant. I guess I might still prefer acalabrutinib in a patient who has risks of these things or who you're really concerned, but with ibrutinib going to market soon as generic, I wouldn't be surprised if insurances start requiring people to try ibrutinib first, and I'm not sure I can say I can blame them for that. Though we did see the grade 3 diarrhea more common in ibrutinib, and I don't think that's surprising. Some of those myalgias, arthralgias that ibrutinib also causes are likely worse than acalabrutinib, but the major effects we didn't see, or I didn't see as much of a reduction as I had hoped for in this trial. And then, not surprisingly, that increased risk of headache is also consistently documented here with acalabrutinib. So then that moves us on to our PI3 kinase inhibitors, duvelisib, idelalisib, and copanlisib. And so PI3 kinase is the phosphatidylinositol 3 kinase pathway, which is part of the AKT-mTOR signaling pathway. It affects a variety of cell functions. It's divided into 3 classes, which are then subdivided into subtypes. And so this is, I like to think of the drug activity in terms of those subtypes, where alpha and beta are expressed in a wide variety of tissues. Alpha is expressed in insulin, or it has a role in insulin signaling, which will be important in our adverse effect profile. Delta is preferentially expressed in leukocytes, and so that's where most of our, or all of our approved lymphoma agents have activity within. And then gamma has activity within, or is expressed in cardiovascular tissue. So looking at our indications for this, idelalisib, or most of these are improved in follicular or CLL, so idelalisib, CLL follicular, copanlisib only in follicular, and then duvelisib in both. And then alpelisib is kind of our black sheep that's approved in advanced breast cancer. So I'll talk about that briefly, though I'll admit that that's not an agent that I frequently deal with. And then the formulation and dosing or in frequency is important with these, where most are oral once or twice a day. However, copanlisib is our standout with once weekly IV dosing. So something especially useful to keep in your pocket for a patient who you might not have confidence that they can handle oral chemotherapy at home, or just don't want to have coverage for that type of medication. So all these agents, to keep it simple at least, they're hepatically metabolized via 3A4 and none require a renal modification. So looking at our toxicity profile, even though these agents aren't used that often, I think it's important to talk about them because they do have a unique and pretty potent toxicity profile. And so the one piece of this is kind of an immune activation type toxicity, once again, somewhat similar to what I think of with checkpoint inhibitors. So diarrhea, you can see an initial chemical diarrhea, similar to what you might think of with something like ibrutinib. Then you also can have a more severe immune-mediated colitis that can present maybe 3 to 6 months after starting the medication. So something we need to keep an eye on for really the duration that a patient's on the therapy. Also, there's this immune-mediated rash, pneumonitis, and LFT abnormalities. So all of which I kind of think along those lines of ICPI toxicity, consider it similar to. So unique profile that a lot of docs might not be watching for that we really need to be weary of. The hypertension you'll see is documented with copanlisib. I suspect that's due to its dosing interval, with it being given once weekly, given that it isn't seen in those other agents. But it is something that can require acute management and that we do need to keep an eye out for. And then similarly, hyperglycemia, another side effect that maybe our oncologists don't manage as much, and so on the breast side, I've heard this can be a challenge managing the hyperglycemia, especially since it occurs in up to 80% of patients. Copanlisib, slightly less common, but you'll see both of these are part of that alpha inhibition, so that's probably where we're getting our hyperglycemia from, and then something we should be managing aggressively to try to prevent delays or cessation in therapy due to these agents. And then the unique thing is the opportunistic infections with PJP prophylaxis required. So not something we typically think of with ibrutinib or other drugs that are used in the same space on our CLL and lymphoma side, but something that has been documented with these agents, and so something we need to be putting on board for these patients. That leads us then to our BCL2 inhibitor, which is venetoclax. And so BCL2 is an anti-apoptotic protein. And so by inhibiting the anti-apoptotic protein, it leads to pretty potent cell death. This is indicated in both CLL and alone or conjunction with an anti-CD20 antibody, can be frontline or in the relapse state. And then in AML, it's licensed in patients unable to tolerate intensive chemotherapy in conjunction with azacitidine, decitabine, or low-dose cytarabine. And so the dosing of this medication, especially at initiation, is quite complicated. All doses should be administered with food, which is part of or leads to improved absorption of the drug. So that is an important counseling point for the patients, especially as we're talking about rearranging when patients might be taking their dose in order to have labs drawn at an appropriate time, something that we should always be emphasizing. It is a 3A4 metabolized drug, and so it's highly susceptible to drug interactions. And so this is something that there's even warnings for things like carvedilol that we don't typically think of as requiring adjustments in therapy. And then in our AML patients where we have azole antifungals recommended as standard of care, coordinating around those drug interactions is going to be quite challenging. And so for CLL, we have a 5-week ramp up, and you can see in the top right corner here, the manufacturer does actually assist us a little bit with this, and that those dosing packs are very helpful for patients in making it easier to start the medication and knowing what dose they need to take on what day. You can see each of the first 4 weeks has its own dosing pack. And so that has been quite successful for patients. I guess the biggest con to that is if you do need to hold a dose or you're trying to go back down on a dose, that can get very complicated very quickly because the medications typically aren't sold in those lower dosage forms. So that can be a challenge. AML, on the other hand, with the lower incidence of TLS risk, has a 3 to 4 day ramp up. Hypomethylating agents cap at 400 milligrams a day. Low dose Ara-C caps at 600 milligrams a day on day 4, and that's continued daily. And that also we frequently see adjustments due to those azole interactions. And so looking at our adverse effects, I really think of this as chiefly being a bone marrow toxic agent. And so we see high incidences of neutropenia and thrombocytopenia in both CLL and AML, with not surprisingly a high incidence of febrile neutropenia in AML. So even though this can be outpatient therapy, still definitely a high risk of infections in these patients, and we need to be watching them closely because of that. The most common side effect that patients report or that they experience home is diarrhea, though in my experience this is typically pretty manageable and something that we can get through with things like Imodium Lomotil. And then the hyperuricemia and TLS risk is much more common in CLL, hence why we have the prolonged ramp up of 5 weeks. That being said, I have, whenever we use this in mantle cell or AML, we've seen a couple times where docs said, you know what, I think this is low risk, and about once a year it bites me in the butt and ends up having TLS in a patient who we thought we were okay in. So I would be using allopure. So how do we prevent that from happening? Trying to follow the dose ramp up where we can, though there is some evidence coming out for more accelerated ramp ups, so we can use that if needed. All patients, though, should be started on allopurinol given the low risk of that intervention. And it's more a coordination thing, just remembering to put this on board 72 hours prior to starting the drug. And then the monitoring for this is very intense. So this is one of the counseling points for patients whenever they're thinking about starting these therapies, is just if they're willing to really make it in for all these different lab appointments right at the start of the medication, there's something like ibrutinib or calibrutinib that's more once or twice a day and once weekly labs that can be easier for people who might live a ways away. So you can see, according to the package insert, these are classified based on risks. So, and there is definition for low and medium risk, and these are both in CLL. So low risk patients, you need 3 different labs, one at baseline, one 6 to 8 hours post-dose, and then 24 hours post-dose for the first 2 escalations. High risk patients, these people are going to be admitted for the first 2 cycles, and they would require every 4-hour labs after dose administration. This is an example just of kind of how complicated it can get, just with the timeline of trying to, so this is an AML patient getting venetoclax to cytarabine. Once again, this has gotten a little easier since manufacturers now are at least routinely approving this. But it is still just complicated whenever you're thinking about when you get approval for venetoclax, when you get approval for decitabine. This patient had a contraindication to posaconazole. The most common one, I would say, is another drug interaction or QTC prolongation. And then trying to think about when you start your antifungal, when you're getting your labs drawn, and then what you're going to meet, where you're going to put your final dose. So for this patient, we actually stopped the venetoclax at 200 milligrams, with the last escalation really being the start of that isofuconazole, since that's a moderate inhibitor and boost you up to the equivalent of a 400 milligram dose. So just something that's very time intensive and requires a lot of effort and thought for patients, and to keep in mind whenever you want to start someone on these. So that brings us more towards the more targeted therapies in AML then, with the FLT3 inhibitors, where we're going to talk about midostaurin in our first gen, gilteritinib in our second gen, and then sorafenib is also used in this space, though I won't be covering it here. So FLT3 is FMS-like tyrosine kinase 3, and that serves an important role in hematopoietic survival and proliferation. There's two types of this one, so ITD, or internal tandem duplication, as well as TKD, tyrosine kinase domain. And so, like some of our other medications, first-gen inhibitors like sorafenib and midostaurin are going to hit several other types of receptors. First, our second-gen inhibitor, gilteritinib, is going to be more potent and selective for FLT3 alone. In addition to first versus second-gen, you also have type 1 versus type 2. And so type 1 inhibitors, I guess I would think of as being preferred in that they inhibit both ITD and TKD, which is both of our approved agents on the market. Type 2 inhibitors, on the other hand, are not effective against the TKD subtype. And this might be more relevant. Sorafenib, I don't expect to be seeing a ton coming up, but as new agents come to the market, quizartinib, I think, is still actively under investigation. This might become relevant again. So looking at our comparison between agents, very different indications that they're currently approved for. So midostaurin is under newly diagnosed therapy for FLT3 positive patients during induction and consolidation. First, gilteritinib, that's really only currently approved in the relapse or refractory space, even though we've had a trial here of maintenance post-transplant. And then we also have the trial open of gilteritinib during induction therapy, which I think we're all pretty excited about. And then you can also see midostaurin has activity in mast cell leukemia and mastocytosis. Because of those different indications that they're approved for, we also have very different dosing schedules. So midostaurin is given twice daily for 14 days during each induction and consolidation cycle, despite being studied in maintenance. So it's not licensed for that in the U.S., and so it's not typically used in that setting. Gilteritinib, on the other hand, is a standard daily dosing, likely due to it being given as monotherapy rather than in combination with chemo. Both are going to undergo 3A4 metabolism, so once again, important to be thinking of those azole interactions in these AML patients. And then looking at our adverse effects, nausea is very common with midostaurin. Patients tell me the pills smell like skunk and are quite awful. And so it is something that we pre-medicate with Zofran for, and then we also see diarrhea commonly with it. Gilteritinib seems to be better tolerated from my perspective, though you still can see diarrhea and nausea with it. Looking at the additional warnings, both will be QTC prolongers, so things that we need to be checking EKGs for, and once again, concerned with those azole antifungals that can both prolong drug exposure and prolong the QTC themselves. Unique toxicity with midostaurin is pneumonitis, and then with gilteritinib is pancreatitis, which we have seen in several patients in the past year or two. Moves us on to our IDH inhibitors, enasidenib and ivosidenib. And so IDH is isocitrate dehydrogenase, and so the mutant variety results in an inability of cells to differentiate and accumulation of leukemic blast. So then our IDH inhibitors then are going to enable that differentiation into healthy cells. Two isoforms, IDH1 and IDH2, function in different parts of the cells. However, both result in this hydroxyglutarate formation. And from an agent standpoint, I tend to think of them as being more similar than different. So here's your comparison table. As you can tell by this point, I definitely love tables. And so ivosidenib is our IDH1 inhibitor, whereas enasidenib is our IDH2 inhibitor. Ivosidenib is approved in both newly diagnosed or relapsed refractory patients, whereas enasidenib at the moment is only in relapsed or refractory disease. Both are given once daily and metabolized hepatically via CYP3A4, so nothing too exciting or different there. Our adverse reactions from a tolerance standpoint, this tends to be pretty good in my experience, some nausea, diarrhea. The elevated bilirubin, especially with enasidenib, is worth calling out and has package-specific recommendations for how to manage that if it does occur, and you can see it's quite common there. Both agents are going to be QTC prolongers. We do need to watch hepatotoxicity with enasidenib, which isn't surprising given the bilirubin incidence there. And then differentiation syndrome is going to be our unique class toxicity here. It's going to require a little bit more oversight and involvement. And so this occurs due to rapid differentiation of myeloid cells. Symptoms can include dyspnea, pulmonary infiltrates, renal impairment, fever, and weight gain and edema, which you can see the percentages reported there. So not the other place you might have heard of this previously is with retinoic acid, which we'll get to next. One of the differences with that syndrome between this and ATRA is that this one seems to be more delayed, where it can occur as early as 10 days or out to 5 months post-treatment. However, we're still going to treat it similarly with dexamethasone if this does occur. So then that brings us over to tretinoin, which is a retinoic acid derivative and is otherwise known as all-trans retinoic acid, or ATRA. And so that's going to be used in APML, or acute promyelocytic leukemia, also as a differentiating agent. So the end product of differentiating to healthy myeloid cells is the goal here. It's given twice daily. It's only available in 10 milligram caps, so it does tend to be a lot of caps for a patient per day. So if you take our 2 meter squared BSA patient, you're looking at about 10 caps per day, though I will say they're pretty small, so I tend not to hear about too many complaints with it. It is an expensive medication, so coverage can be a challenge with these people. So it's something we need to really hop on right away once they have this diagnosis to make sure there aren't any lapses in therapy. It's hepatic metabolism via non-3A4, which is convenient, and then no renal or hepatic adjustments. So our big side effect is differentiation syndrome, and so you can see the earlier time course here, hours to 1 month after initial dose. We do use prevention in certain patients with prednisone, and then treatment, once again, is going to be dexamethasone twice daily. The other metabolic side effects of this can be challenging to manage, and so it's hypercholesterolemia, hypertriglyceridemia, and so we have had to initiate this in patients. And because this is really the only agent in this class, whenever you have severe side effects come up, it can be quite challenging because there isn't really anything easy to swap out for it. So something that we can typically manage, but every once in a while can really be a challenge for patients. And then with those other metabolic effects, I think it's not really surprising that we also see LFT abnormalities in this group. And so then that brings us to our JAK inhibitors, ruxolitinib and fedratinib. And so ruxolitinib is a Janus-associated kinase, so JAK1 and 2 inhibitor. The JAK-STAT pathway is a cytokine expression pathway. It's important in hematopoiesis and cell and immune function, undergoes hepatic metabolism with some urinary excretion of active metabolites, and so it will require a renal adjustment in certain patients. This is approved in myelofibrosis, polycythemia vera, steroid refractory acute graft versus host disease, and then hot off the press last week, also approved in chronic graft versus host disease, which I'm really excited about. And so dosing in myelofibrosis is really based on on the initial platelet count, which is going to pertain to the side effect profile that we're about to talk about. Steroid refractory disease, the FDA still recommends this dose ramp after 3 days, even though it's not what they did in the phase 3 trial that was published later. Probably something that's based on blood counts for a patient. If they have lower ANC or platelet concerns, then the ramp up makes sense. My biggest concern is whenever we start it at the low dose in patients and then forget to ramp them up to the full dose, even though they would tolerate it just fine. So looking at our toxicity, this is in some ways reminds me of venetoclax in that it's really a bone marrow toxic medication. So we see high incidences of anemia, thrombocytopenia, and neutropenia. Not surprisingly, they're more common in our GVH population who might have more fragile counts post-transplant. And then because it's a cytokine suppression medication, it is going to be associated with infections, especially in GVHD patients. Fedratinib then is a selective JAK2 inhibitor with hepatic 3A4 excretion, hepatic 3A4 metabolism, also with renal excretion. So it does require a dose adjustment at those renal creatinine clearance less than 30. And it can be used in myelofibrosis after patients progress on ruxolitinib or are unable to tolerate it due to toxicity. Looking at that toxicity, probably the biggest benefit in kind of poor comparison is in anemia. So you can see the higher percentage reported in the ruxolitinib trial compared to that in fedratinib. And once again, some of these patients in this trial might have been ruxolitinib intolerant to start with, so possibly a selected population, but the thought is less anemia and thrombocytopenia with this medication. A little surprised at how high the reported diarrhea and nausea are with this medication. I guess thinking about it now, I wonder if the splenomegaly associated with myelofibrosis contributes to this nausea. It isn't something that I've had to manage extensively, but something to be aware of. And then the big unique toxicity for this medication is the Wernicke's encephalopathy, which delayed its coming to market by about a year or two. And so we should be getting thionine levels prior to patients starting therapy, which is a send-out lab and does take time to return, so something that we should be planning for. And then we do need to replete that prior to initiation. And once again, I suspect that the splenomegaly and nutritional deficiency associated with that, with patients' loss of appetite, probably contributes, in addition to some unique drug effects that, for whatever reason, could potentially precipitate that side effect. And so kind of bringing it back together, whenever you're thinking about these oral chemotherapy medications, obviously it's a lot of info. So I try to group things by class and mechanism and, to draw lines towards toxicity and dosing guidelines for these agents. The general assumption is that these agents are metabolized by 3A4. We need to be aware of interacting meds or big things to watch out for: azole antifungals, especially in AML, and then any anti-epileptic drugs or post-transplant medications and like solid organ transplant recipients are going to be a concern. And then for renal hepatic dysfunction, not a great heuristic I can give for that, so you'll have to check the specific agent for dose modifications. And so that's kind of the overview. I guess I'd be happy. I thank you for your time, and I'd be happy to answer any questions you guys might have.